CT scan to evaluate for lung cancer, and she is found to have 11 millimeters nodules in the left upper lobe. What is your next step, diagnostic step? A, CT scan at 12 months, B, CT scan at 24 months, C, PET scans, D, immediate lobar surgical resection.
All right, maybe what I'll do, because these may be kind of hard, is I'll give you guys like 20 seconds and I'll do by show of hands. I'll give you time to think about it. All right, so who thinks A? Who thinks B? Who thinks C? And who thinks D? All right, we got to kind of a little bit across the board, so probably get something good to go into. So this is really just evaluation of lung nodules. And I'm not really going to go into what to do too much when they're less than 8 millimeters. You know, at this point, really it comes down to you're going to do serial CT scans. The only time that you may not need to do a serial CT scan if it's less than 6 millimeters and it's a low risk patient. And low risk meaning someone that's younger, doesn't have any smoking, it's not, you know, it's not a spiculated nodule, it's not in the upper lobe. That would be like a low risk patient. So I'm not going to go too much into that, but this is really getting on once you find a larger nodule greater than 8 millimeters, you know, what do you do then? And there's a kind of a couple different things you can do. And really you want to first stratify that nodule as, is this a low risk nodule? Is this an intermediate risk nodule? Or is this a high risk nodule? And it's actually kind of hard to be a low risk nodule. I mean, the first thing you have to be is you have to be less than 40 years old. So anyone that's over 40 is already either going to get a PET CT scan if it's greater than 8 millimeters or get a biopsy or excision. Choosing between these is a little bit more difficult and nuanced. High risk, this would be like just a situation of high risk would be like a 2.8 centimeter nodule. And remember, nodule, once it's greater than 3 centimeters, it's not a nodule anymore. It's a mass. So this would be like a 2 centimeter nodule in like an old patient that has a smoking history and it's like spiculated in the upper lobes. So we're kind of here. And when you're kind of here, you really have to do a PET scan to kind of help you first see if it takes up a lot of FDG, a lot of glucose, means it's metabolically active, means it's more likely to be a cancer. And you're also looking for lymphatic spread, which is helpful too, which can help with your surgical planning. So we're there. So the correct answer here was, you know, go to a PET scan. I didn't want to get too much into nodules, but I did want you to say, you know, what do you do when it's greater than 8 millimeters? And most of the time, you're going to do a PET scan, unless it's really, really super high risk. And if they ask you that question, you'll kind of know it because you're like, okay, this is cancer. All right, so getting a little bit more into it. So this is still the same patient. The patient gets the patient gets a PET scan, and you can see that this cancer lights up here. It also lights up in the hilar lymph nodes. She gets a EBUS, which shows adenocarcinoma, so lung adenocarcinoma, and she has a DLCO of 80% and FEV1 of 65%. So the question here is, what do you want to do for this patient? Do you want to do a full lobectomy plus radiation, a full lobectomy plus chemotherapy? Do you want to do a wedge resection plus chemo, or do you want to do a wedge, radiation, and chemo? All right. Give you a couple seconds. And we'll just be showing here for this one too. All right, who thinks A? Who thinks B? Who thinks C? And who thinks D? All right. So I will give you it after I kind of go through just how I think about solid cancer. I think about solid cancer evolution, right? So we'll probably spend a lot of time on this slide. So this is a normal cell. When a normal cell is, a lot of times exposed to things that cause non-lethal genetic damage, it can undergo dysplasia, right? And this can be smoking, this can be acid with someone with GERD, this can be aniline dyes for someone with bladder cancer. This can be a lot of things. But this non-lethal damage does things. It changes your genes. So one of the first genes that it can change is your tumor suppressor genes. So your tumor suppressor genes are really genes that are mostly involved in like cell division and involved in genetic damage repair. So these can be a few. One of the major ones that we see a lot is BRCA. This is BRCA is needed in the cells for non-homologous repair, meaning double-stranded DNA breaks are fixed by BRCA. Another one that you can think about is like MSH, those microsatellite pathways with Lynch syndrome, and that's really to fix very small breaks in the DNA, more like single-strand breaks in the DNA are fixed by MSH. If someone gets mutations in MSH, they can get Lynch syndrome, which is usually colon cancer as well as gynecological cancers. And then another one is a big one that we don't really have much treatment for, but is present in a lot of cancers, P53. And P53, the thing that it's involved in is when a cancer cell undergoes genetic damage, P53 actually shuts down their cell, the entire cell cycle, and shuts down cellular division, making sure that that cell that could undergo neoplastic transformation does not replicate anymore. So P53 is a very important one. And then you can also have mutation in your oncogenes. And the oncogenes are the ones that we've really been able to target. So these oncogenes that a lot of times may be mutated in patients with cancer could be things like growth factors. So big ones are like EGFR, epidermal growth factor receptor. This is present in lung cancer, some of the squamous cell cancers. Another one that you have to think about is HER2, another growth factor present in lung cancer. VEGF is a vascular growth factor involved in getting tumors more blood so they can replicate quicker. That's implicated specifically in colon cancer. There can be secondary messenger receptors that are involved in really telling cancer to turn on and to start replicating. So one of the big one here is going to be RAS. Also ALK is another one. And then it could either be like anti-apoptotic proteins like BCL2 and CLL. So really, cancers develop these acquired mutations. And when they develop these acquired mutations, they turn into carcinoma. They turn into really monoclonal cells which forget to die. And that's really the thought process of cancer. These are monoclonal cells that forget to die. And then those monoclonal cells which forget to die, they're already at really high risk of developing new mutations because they're growing quickly and some of them are not fixing their genetic damage. So they really have what we call neoplastic evolution. And that neoplastic evolution, really what happens is that the clone that then becomes the highest replicating clone and the more resistant clone is then the one that's selected for. And eventually what happens is that with more mutation, these cells can start turning into invasive carcinoma. They can they can basically invade through the bone marrow. They can go into your lymphatic system. They can acquire adjacent spread. And then the last thing, and the thing that, once it gets really, really hard to treat and almost impossible to treat, is that it eventually spread hematogenously and you can have mets to other organs. That's kind of like the last stage. So the question is here, how do we treat solid cancer? And I'm really basically going over the big ones here: breast, lung, colon, prostate, pancreatic, bladder, head, and neck. And these are really going to be a general overview of all of these cancers, right? So how do you treat it? So this is kind of from Navi's golden rule. Just remember, surgery, radiation, you can do with curative intent for solid cancer. So if you want to cure solid cancer, you have to completely get rid of it in some way. You have to cut it out or you have to radiate it. And then just remember, once you're doing chemo, targeted therapy, or immunotherapy, this is not really for curative intent anymore. Yes, you're hoping that they can, and in some very rare cases, they can be cured. But it's really, really uncommon. And your goal really is to shrink any cancer that you can't resect, or decrease the amount of macro or micro metastases. So how do we treat it, right? So for localized cancer, so this is cancer within the organ, what do you guys think would be our first treatment option for really any of these cancers? How do you think what do you think is the biggest thing we would do to treat this? Yeah, Rakai says, yeah, exactly. So surgery. So if you surgically resect this cancer out and, you don't think that there's any macro or micro metastases, this can be a cure. All right, so surgery is really going to be an option for every single one of these. So every single one of these cancers, surgery is going to be an option when it's localized only within that organ. Does anyone know, out of these cancers, which ones you can use radiation for as an option in a first-line therapy? Yeah, it's kind of a hard question. So you can use radiation as a first-line therapy, specifically in prostate, and head and neck. And then if you guys remember, with breast cancer, it's an adjunct. So in someone who's getting lumpectomy with breast cancer, you want to do radiation as well. Or if you're doing double mastectomy, it's high risk, like the invaded one, the chest wall or the skin, you also want radiation in that setting. So really the only time you're going to use radiation when any of these solid cancers are localized within an organ is prostate, head and neck, or as an adjunct in breast cancer with lumpectomy. And then in only certain circumstances with solid cancers would you use chemo while it's still localized in that organ. And really the reason why we do this is in some of these specific ones, so breast cancer and pancreatic cancer, there's a very high risk of micrometastases, even though on imaging it's just localized within that organ. So really in high-risk breast cancer, which is your triple negative or HER2, in high-risk breast cancer, you're going to use chemo even when it's still within that organ on imaging because you're worried about micrometastases. And then you also will use, in bladder cancer, you'll use topical or intravesicular BCG. And in bladder cancer, even when it's very small, it's only invading like the submucosa in the bladder, you do this topical BCG, this intravesicular BCG, actually to prevent recurrence of bladder cancer. All right, so once you get lymphatic spread or adjacent spread, what do you think is going to be your treatment for these patients? In addition to kind of the things that we already went over. Just in general, what's the general treatment that these patients now may need? I don't know if this question's too easy or too hard. There we go, chemo. Yeah, exactly. So really, once you get spread, lymphatic spread or adjacent spread in any of these solid cancers, you're going to need chemotherapy. And then in some cases, you may also do targeted therapy. So remember, targeted therapy is going to be something that mostly is going to be targeting these oncogenes that are turned off to turn these oncogenes off. So the only time at this stage before it's metastatic that you're going to use targeted therapy is going to be head and neck, and you can use an EGFR inhibitor like cetuximab. And then also breast cancer, if it's HER2 positive, you're going to use targeted therapy within this stage. All right. So let's kind of get back to our question with all that in mind, right? So this patient has, basically lymphatic spread. So what are we going to do here? And really, we're going to have to do surgery, and we're also going to do chemotherapy. As we were saying here, radiation is not used often once you have lymphatic spread or adjacent spread. Radiation is just used as the first line in prostate, head and neck, and adnexal breast. And then since this patient is now spread to his lymph nodes, we really want to decrease. You can probably guess that it's going to be spread. There's going to be micrometastases to the rest of their body. So you want to do chemotherapy to shrink that lymph node, but also to shrink any micrometastases that the patient has to the rest of the body. And then there is also a bit of a nuanced question here in which any patient that has lung cancer needs a lobectomy. Never do a wedge resection. It's been shown that they have a decreased mortality with lobectomy and chemotherapy. I put in the patient's PFTs. This is almost like a red herring. If the FEV1 and the DLCL are greater than 60%, then they can tolerate a full lobectomy, which the patient is here. So that kind of goes into what is our treatment for non-small cell lung cancer. So if you remember non-small cell lung cancer, the staging, this is one Navi kind of showed me. The stage 1 is going to be an isolated lung lesion. Stage 2 is going to be hilar lymph node spread. Stage 3 is going to be usually mediastinal or like adjacent spread. And then there's 3A, which is resectable, and 3B, which is non-resectable. And then 4 means there's MET. So here's a MET to the other lung, but you can have a MET to the pleural, you can have a MET to the brain, liver, really any of those. So that's kind of the staging of non-small cell lung cancer. Mostly for treatment, it kind of goes into resectable versus unresectable. So going through treatment-wise, surgery for all patients, and remember, with lung cancer, lobectomy versus wedge resection. You only need radiation and kind of if someone can't get a surgery, or if you try to cut that tumor out and they have positive margins, which we didn't have here. And then remember, chemotherapy, anytime it spreads to a node, or if it has adjacent spread to another organ. So in this patient, they had adeno, they would have got surgery, and then they would have had cisplatin and pemetrexed because they had adenocarcinoma. So that was the correct answer, was surgery with a full lobectomy and chemotherapy. Didn't need radiation in this case because we cut it all out and they were a surgical candidate. Any questions about that one? All right. Someone read this one for me?
I can read it. The same 66-year-old female with a past medical history of hypertension, smoking, mild COPD presents to your oncology clinic for her lung cancer follow-up. She was diagnosed 1 year ago with stage 2 lung adenocarcinoma and was treated with lobectomy and chemo, cisplatin and pemetrexed. She notes now she's getting low-grade fevers and weight loss in the last month. She's chest CT at 6 months, which was normal. She undergoes CT chest, abdomen, pelvis, and shows metastases to her adrenals, liver, right lung, with right-sided pleural effusion. She has good functional status. What is the next step of management? Systemic chemotherapy, immunotherapy, biopsy, and test for driver mutation or hospice.
All right, so I'll give you guys a couple of seconds, and then I'll do a raise a hand as well for this one. I know these questions are really tough. These are some questions that you don't really learn that much, I think, in residency, but they're tested a lot on the mixed staff on the board. So.
Actually, there's systemic.
Or unless you want to answer this one, Fred. Oh, no. Okay. All right. So by raise of hands, who thinks systemic chemo now? Who thinks immunotherapy? Who thinks biopsy and test for driver mutations? All right. And then who thinks hospice? All right. So I had the most for C, and C was right. So kind of getting into, treatment-wise for once, just in general for solid cancer, once we get to metastases, this is when you start thinking more about immunotherapy. And also you start thinking about more targeted treatment, right? So targeted treatment meaning treatment of those specific oncogenes that cause cancer. So kind of just going into immunogenicity of cancer, just remember that, cancer is an immune phenomenon. Your immune system is trying to fight cancer all the time while you have it. And the way that your immune system really does this is by CD8 cells as well as NK cells. So remember, CD8 are those cytotoxic T cells, NK cells are your natural killer cells, and they're really going around the body and actually looking for tumors expressing specific antigens that tell your body that this is foreign and this is like an oncogenic cell. So unfortunately, tumors have evolved really to evade the immune system. And there's a couple ways that they do it. So the first one, so you remember any antigen that's within the cell is expressed by MHC1. So here's MHC1 with the antigen. And that is the thing that the T cell receptor will actually attach to tell the T cell whether it's a foreign versus local antigen, right? So one of the ways that cancer cells can evade the immune system first is by actually getting rid of their MHC1. They can actually downregulate this and not have MHC1 anymore. Another thing that they can do is they can start actually presenting self-antigens. So they may present antigens that look like other things in the rest of the body, and they are antigens that are present in the body, and that can actually lead to immune tolerance from the CD8 and NK cell. Also, this is likely what leads to a lot of the paraneoplastic disorders. Things like SIADH, things like Cushing syndrome, things like limbic encephalitis, because the body, which is trying to fight your tumor cells, then decreases its self-tolerance from the self-antigens that are expressed to the CD8 and NK cell. And these CD8 and NK cells may think that these self-antigens are foreign because they're expressed by a tumor cell, leading them to attack those same antigens in the rest of the body, which could be the neurons with, neurologic paraneoplastic disorders, which can be, really anything from the paraneoplastic antibody perspective. And the last thing that these do, and this is the thing that we target, is tumor cells will actually express inhibitory T cell molecules. So some of the inhibitory T cell molecules that they'll express is going to be PD-L1 or CTLA4. And basically these expression of these molecules actually downregulates CD8 and NK cell attack of that tumor cell. So it actually downregulates the T cell response, allowing these cancers to evade the immune system. And that's actually one of the big things that we treat with immunotherapy. So you can have immunotherapy that are things that attack PD-L1, things that attack CTLA-4, like pembrolizumab, adalimumab for PD-L1, ipilimumab for CTLA-4. But as you guys remember, an obvious side effect of this is decreased self-tolerance, and then pretty much autoimmune reactions in which the body attacks the body, and then you end up getting things like colitis, pneumonitis, dermatitis, hypophysitis, things like that. And then there's also targeted therapy, and this is really attacking those oncogenes, things like HER2, EGFR, ALK, EPC, etc. So kind of talking about this in general, mostly once we get to the metastatic phase, here is when we start thinking about immunotherapy. I think in the future it'll probably be earlier on, but really once it gets to the metastatic phase, we start thinking about targeting the immune system to actually help fight these cancer cells, and then really specifically targeting those driver mutations as well. So for non-small cell lung cancer, really once it's non-resectable or metastatic, your next treatment is really going to be based on your driving mutations. And this is why in this case, really what you want to do next is biopsy and test for driving mutations, because if there are present of those driving mutations, or if there is greater than 50% PD-L1, that's going to be your next treatment. EGFR, if they have this for adenocarcinoma, you can treat with erlotinib, or a new one is osimertinib. If they have an ALK mutation, you can treat with crizotinib. If they have a RET mutation, this is new. You don't need to know this. It's new. Or if they have a greater than 50% PD-L1, you can treat with like pembrolizumab, like immunotherapy. If they don't have that, really any of those driver mutations where they have less than 50% PD-L1, then you're kind of stuck treating their metastatic cancer with chemotherapy. All right. Anyone want to read this one?
Same 66-year-old female with past medical history of hypertension, smoking, mild COPD, presents to your oncology clinic for her lung cancer follow-up, diagnosed 1 year ago with stage 2 lung adenocarcinoma, and was treated with lobectomy plus chemo, which was cisplatin pemetrexed. Now with recurrence with metastasis to the liver, adrenals, lung, and pleura. She is negative for driver mutations and positive for greater than 50% PD-L1, so she undergoes immunotherapy with pembrolizumab. She feels well, other than anorexia. What's your next step in management? A, repeat thora, B, chest tube placement, C, continued monitoring, or D, pleurodesis.
So anyone who's on Blue 3-4 may know kind of the treatment algorithm for malignant pleural effusion, but this is kind of what that's getting at. So who thinks we do a repeat thoracentesis? Who thinks we do a chest tube? Who thinks we just continue monitoring and don't do anything? All right. And who thinks we do a pleurodesis? All right. So trying to go into malignant pleural effusion, the first step is the patient symptomatic or is the patient asymptomatic? So this patient's really asymptomatic, right? She feels well. She has a little bit of anorexia, but that's because she has metastatic cancer. So she's asymptomatic. And when a patient's asymptomatic with a malignant pleural effusion, and you already proved that they have metastatic disease, so it's not for diagnostic, you actually just monitor clinically. Does anyone know for symptomatic pleural effusion what the first line treatment is? Do you do, I'll give you two options. Do you do a chest tube placement, or you just do a thoracentesis, like a large volume thoracentesis ×1? Does anyone know? So you just do a single large volume thoracentesis, and you're hoping that you do this thora, it goes away, it doesn't reaccumulate. But if it does reaccumulate, in that setting, you're pretty much going to be placing an indwelling catheter. So this is really our first go-to. You'll probably consult pulmonology. Dr. Hain will put a indwelling catheter in. The nice thing about an indwelling catheter is that a lot of times, once you place this over a couple of weeks, the patient may self-fluoridese, and they'll actually be able to stop draining that malignant pleural effusion. The only thing is you want to make sure they have a greater than 2-week life expectancy before you do that. If they don't really have a recurrent or they're, less than 2 weeks life expectancy, you just kind of monitor clinically. And this was kind of, I put this together because I feel like this question came up a lot on Blue 3-4 is like, when do you put a chest tube in? When do you do like a pleurodesis? When do you do just a general thoracentesis? So I thought this chart was kind of helpful. This is kind of crazy. When you see a malignant pleural effusion, that usually means they're really in end-stage disease. And I was kind of shocked by what their median survival in days were. So, I mean, once you get to any of these cancers down low, on average, they have a less than 6 months to live. And urological cancer, I mean, usually the median is like basically a month to live. Melanoma, it's about a month and a half. Sarcoma, it's about a month and a half. GI cancer, it's only 2 months. So once someone has a malignant pleural effusion, I mean, it is a really bad sign of really severe advanced disease. So I just want to try and get you in your guys' head. All right, I'll read this one. All right, same lady. So she was treated with immunotherapy with pembrolizumab. She presents to the hospital later with failure to thrive and worsening weight loss on the pembrolizumab. The CT scan shows worsening of her metastatic disease, so you can see these big mets to her liver. Her family notes that she, now is so, she's pretty deconditioned. She just kind of lays in bed most of the day. And they say they need, to help her with most of her activities of daily living. So the question for now is, what's the next step of management for this patient? Do you want to switch to systemic chemo from the pembro? Do you want to re-biopsy to look for a driver mutation? Do you want to do hospice, or do you want to resect the largest mets? All right. Who says A? He says we want to re-biopsy, look for driver mutations. Who says C, hospice referral? All right, and then who says D, resection of largest mets? So, and anyone who said hospice referral was right. Can someone explain me what makes you think we should do hospice in this patient specifically? I know maybe it might have been a gut feeling, but there is kind of a systematic way to approach this. Maybe what in her history says she wouldn't do well with systemic therapy.
Her functional status.
Perfect. Yes. And can you tell us a little bit more about that, Ellie? Just in this patient?
She can't do any activities of daily living or something along those lines. So she her ECOG status. I don't actually know what it is, but I'm sure it's not good enough for her to get any systemic therapies.
Perfect. And that's one of the biggest things when you're on Blue 4, when patients come in, they have metastatic disease, they're having failure to thrive. Offering them chemotherapy would actually hurt them. So this is what Ellie was talking about. This is the ECOG performance status. So they have 1. So 0 means that's just me and you, fully functional adult. 1 means they're restricted in strenuous activity, but they can do some, light work. 2 means, they really can't work, but they're still up and about for about more than 50% of waking hours. And then once you hit 3 and 4, this is when you stop offering systemic therapy for, at least for metastatic lung cancer. So once the patient's confined, this is kind of the thing I look at most. If you're going to remember one thing, once the patient's confined to the bed or chair for more than 50% of the day, giving them systemic chemotherapy for most of your solid cancers, if not all of them, it's not going to be helpful, and it actually can increase their chance of death, of dying. One of the craziest studies was that was recently done is any patient with metastatic disease, a palliative care consult actually decreased their mortality. And obviously there's difference with palliative care and hospice, but any patient with metastatic disease and non-small cell lung cancer, make sure they have a palliative care consult. If they come to your hospital, make sure they at least have a follow-up with palliative care. That actually decreases the mortality, and most likely, probably because it decreases the amount of chemo they can get, especially when they have really poor functional status. So yeah, just remember this one. Always ask about functional status in your patients with cancer coming to the hospital with, complications of metastatic disease. All right, what time did we get? 25. All right, I think this will probably be the last one. And I know these questions are really, really tough, so I apologize, but, I want to give you guys a little bit of, once you, like the stuff you're going to see once you start studying on the mixed app, and try to give it to you in a little bit of easier way. So yeah, I apologize. Maybe this was a little bit cruel. These questions are really tough. So this was a famous singer, no past medical history, comes to your office with worsening hoarse voice for the past 1.5 months. He has a 30-pack smoking history. Patient undergoes laryngoscopy, which shows a small mass in the vocal cord without fixation or limitation in mobility of the vocal cords. CT scan shows no invasion of the surrounding cartilage and no lymphadenopathy. Biopsy shows P16 positive squamous cell lung cancer. Patient wishes to preserve his voice as much as possible. And you can see here is imaging of that cancer right there on the vocal cords. So the question is, we have localized disease. So what is the correct treatment for this patient? Do you want to do cisplatin radiation? Do you want to do radiation alone? Do you want to do partial laryngectomy? Or do you want to do total laryngectomy, chemo, and radiation? All right, who thinks, let's do cisplatin and radiation? Who thinks let's do just radiation? Nice. Who thinks partial laryngectomy? And who thinks total laryngectomy, chemo, and radiation? Perfect, okay. So head and neck cancer, I'm gonna skip this one and kind of go through the whole thing. When a patient has more localized early stage disease, that maybe it can go into like the cartilage, but it's not going to go into any other surrounding structure, surrounding organs. Really the major treatment here is going to be surgery or radiation. You can pick one or the other. Remember, it's localized to its organ. You think that you can resect it totally out. So you're not going to need any of the other systemic treatment like chemotherapy. So the option for head and neck cancer with surgery versus radiation really depends on, can it be cut out and what are the surgical complications? So in this patient, he's a singer, it's on his larynx, you cut it out, he's actually going to lose his voice. So that's why this patient was more radiation therapy. Once you have advanced disease, and the thing about head and neck cancer, a lot of times it is advanced, and it can really invade into a lot of the surrounding structures. Once you get there, you really can't cut it out anymore. It's going to be too hard to surgically resect when it's that advanced. So radiation and chemotherapy. And treatment for it would be cisplatin or cetuximab, which is that EGFR inhibitor. Really, right now, the guidelines are do radiation and cisplatin. But patients that have renal disease or they already have peripheral neuropathy or intolerant to cisplatin, you can go straight to radiation and cetuximab. Probably in the future, it probably will be radiation cetuximab just because cetuximab is a little bit less toxic. All right, so that is our treatment of head and neck cancer. We'll do one last one for bladder cancer. So this is an 81-year-old male, evaluated 2-week history of gross hematuria, former cigarette smoker. He undergoes an ultrasound, it's normal. He does a cystoscopy, finds this lesion on the bladder wall. It's a high-grade stage 1 T1 transitional cell carcinoma that's evading the subepithelium. So epithelium and just a little bit of subepithelium, but not the muscle. What is the most appropriate treatment? And this is a question I actually copied from, I think one of our board tests. I remember getting asked this. Dana remembers it too. All right. So what's the following treatment for this patient? Do you want to do systemic chemo? Do you want to do intravesical, means bladder, BCG? Do you want to do a intravesical or bladder BCG followed by partial cystectomy, or do you want to do a partial cystectomy? Going through this one, who thinks A? Who thinks B? Got some B's. Who thinks C? And who thinks D? All right, so kind of going into bladder cancer, treatment is anyone that's TA or T1, meaning does not, it's really, just think about the muscle. If you remember, really the treatment cutoff is whether it invades the muscle or not. So TA, meaning it's only really evades the epithelium of the bladder. You just do a TURP, which is, transurethral surgical movement, plus 1 dose of BCG. If it goes into the subepithelium, you do a TURP, plus 6 treatments of BCG. And once it gets to the muscle, that's when you really can't remove it all with a TURP anymore. And in that case, once it gets into this is really the big thing you're looking at, and probably is going to be the main prognostic indicator for patients with bladder cancer, is if it's muscle invasive or not. Unfortunately, if it goes into the muscle, you have to actually do a full cystectomy. So you actually have to remove the entire bladder, and then really plus minus chemo. Mostly you do chemo, like we were saying earlier, and this is systemic chemo. If there's adjacent spread, so if it actually spreads all the way through the bladder wall, or if they have lymphadenopathy. So kind of going over everything that we just taught, I think this is probably the easiest way to think of it. So just remember, I kind of try to remember what's the general treatment for all solid cancers, and what are the things that don't follow that? So general treatment for a localized tumor for any of these is surgical resection. You can do it with all the above. Radiation is an option first line for head and neck and prostate, and it's always added for breast lumpectomy or high-risk mastectomy. Now he's going to go into this Thursday. Chemo, when that cancer is only localized within that tumor, is only for pancreatic or high-risk breast cancer, or you can do intravesicular chemo with bladder cancer. Once you do, really for most of these, other than the ones we just talked about, for any of these organs, once you have lymphatic or adjacent spread, that's when you add in chemo. And in some cases, like head and neck or breast, targeted therapy. And really, once you get into metastatic disease, this is when you start thinking about immunotherapy. We don't really add it before metastatic disease in any of these solid cancers. And then that's when you start really thinking about, especially lung cancer, targeted therapy as well. On all these patients, we can get chemo. But don't give them any systemic therapy if their ECOG status is greater than or equal to 3. Cool. And then there's a lot of material. Did anyone have any questions? All right, cool. Thank you. Can't log out.